In 1989, in Bangkok, the HIV infection rate among people who inject drugs didn't just climb, it exploded.
Right, yeah.
It increased by an estimated 4% every single month. And, you have to ask yourself, how does a virus physically move through a human population with that kind of terrifying velocity? Like, what specific environmental and mechanical levers are being pulled to facilitate that kind of exponential biological spread?
It's a staggering epidemiological event.
It really is. Welcome to this deep dive, everyone. I am your host, and I'm joined by our resident public health expert. And for our journey today, whether you're a medical student cramming for your boards, a public health trainee, or a practicing clinician trying to make sense of the complex clinical presentations in your waiting room, I want you to picture a river.
I love this metaphor.
Right. So we are going to look at the massive, complex apparatus of global public health as a river system. When a community is drowning in that river, pulling them out of the water downstream is essentially, well, it's the equivalent of emergency medicine.
Yeah, exactly. It's the administration of naloxone in the back of an ambulance or the crash cart in the ED.
Exactly. That downstream rescue is undeniably vital. But the public health mandate is fundamentally different. Our job is to hike miles upstream and figure out how to engineer and fix the broken bridge they are falling from in the first place.
That is a highly accurate framing mechanism. And, to map that river in the context of our discussion today, which is focusing heavily on the public health aspects of illicit psychoactive drug use, we have to recognize what forces are actually shaping the landscape.
Right.
The river itself, the channel it flows through, it's carved by massive global markets and deeply entrenched illicit supply chains. The water rushing past you, actively pulling patients out of the surface, represents the biological reality of neuroadaptation, the physiological dependence, the molecular changes occurring right at the receptor level in the brain.
And the structural dams, the early warning radars we try to construct along the banks.
Those represent our policy frameworks, our epidemiological surveillance methods, and, of course, our harm reduction programs.
And just to set our specific mission statement right at the top so you know exactly what we're doing, this deep dive is a structured, conceptual companion to Chapter 9.2 of the Oxford Textbook of Global Public Health. We're not just going to read you a summary of the text. You can absolutely do that on your own time.
Yeah, that would be pretty boring.
Very boring.
Yeah.
Our goal here is to dynamically map these concepts out, to clarify the underlying frameworks, and really strengthen your clinical reasoning so that when you read the chapter, the architecture of the information just makes complete, intuitive sense.
To build that solid architecture, we really must first establish the baseline epidemiological reality. If we look at the global burden of disease project data spanning from 1990 to 2010, the deaths directly attributable to illicit drug use more than doubled globally.
Wow.
Yeah, jumping from around 68,000 to over 157,000. And disability-adjusted life years, or DELIs.
Which, as a quick reminder for those listening, represent the sum of years of potential life lost due to premature mortality and the years of productive life lost due to disability.
All right, thank you. So those dailies surged from 15 million to nearly 24 million.
Which is just a staggering trajectory. And here's where we really need to maintain a rigorous clinical perspective. The textbook points out that these raw numbers are actually quite modest when you compare them directly to the absolute titans of global morbidity.
That's a critical point of context. I mean, nicotine and alcohol command the highest mortality and morbidity on a global scale by a massive, massive margin. In 2010, tobacco smoking accounted for over 5.6 million deaths.
5.6 million?
Yeah, and alcohol use was responsible for roughly 4.8 million. Illicit drugs account for perhaps 0.5 to 1.3% of all adult deaths globally.
Nah.
However, the use of illicit drugs, specifically cannabis, opioids, cocaine, and amphetamine-type stimulants, which we'll refer to as ATS moving forward, they trigger profound, tightly clustered cascading effects. We're talking about severe infectious disease transmission localized in marginalized communities, devastating and highly visible overdose clusters, and massive social, legal, and family disruption.
Stuff that fundamentally destabilizes the social determinants of health.
Exactly.
So, to navigate all of this cascading complexity without getting lost in the weeds, we're going to utilize a core analytical spine for our discussion today. Every single concept, mechanism, and policy we unpack is going to map onto a specific linear pathway.
Right. The risk to exposure pathway.
Yes. Risk leading to exposure, leading to an outcome, necessitating an intervention, which then ultimately has a system impact. Risk, exposure, outcome, intervention, system impact.
That structural framework will really keep our clinical reasoning securely anchored as we move back and forth between microbiology and macro policy.
Let's hike upstream to the very beginning of that pathway. Before we can effectively treat the individual patient sitting in front of us in the clinic, we have to deeply understand the macro environment that supplies the exposure. We need to look at the global epidemiology of illicit drug use. So what do the numbers actually look like from a macroeconomic perspective?
Well, the most robust estimates we have for this period come from the United Nations Office on Drugs and Crime, the UNODC, specifically detailed in their 2012 World Drug Report. They estimated that globally, between 3.4 and 6.6% of the adult population.
And epidemiologically, adult is defined as people aged 15 to 64, right?
Correct. So 3.4 to 6.6% had used an illicit drug at least once in the previous year.
Okay, but out of that massive global cohort, how many are we actually classifying as having a severe clinical problem as opposed to just transient or experimental use?
Roughly 10 to 13% of those past year users are considered problem users, meaning they're actively dealing with established drug dependence or complex drug use disorders that require clinical intervention. Now, when we disaggregate the data by specific substance, cannabis is by far the most prevalent universally.
Not entirely surprising.
No. We are looking at an estimated 120 to 224 million users globally.
And what about the other major pharmacological categories?
They trail significantly behind cannabis in terms of sheer numbers, but they're roughly clustered together in prevalence. Opioids, cocaine, and ATS amphetamine-type stimulants each have an estimated 35 million users globally.
But if I look at a global map of substance use, I know these exposures aren't spread evenly across the globe like peanut butter. There are highly specific, deeply entrenched geographic footprints for these substances.
Absolutely. Oceania and North America report the highest overall levels of cannabis use. But when we look at opioids, the geographic specificities become incredibly telling regarding how exposure is generated. In North America and Australia, prescription opioid users actually outnumber traditional heroin users.
Wait, really? Outnumber?
Yes. It is fundamentally a pharmaceutical-driven exposure. It's heavily influenced by historical prescribing practices, aggressive pharmaceutical marketing, and the structural design of the healthcare system itself.
Well, in Eastern Europe, the exposure profile is entirely different.
Yeah, in Eastern Europe and Southeastern Europe, heroin remains the overwhelmingly dominant opioid. But then you encounter highly localized, specific anomalies that really challenge our general assumptions.
Like what?
Well, in Estonia and Finland, synthetic opioids like fentanyl and buprenorphine have largely replaced traditional heroin entirely. In Russia, recent historical heroin shortages led to rapid, devastating surges in the domestic, clandestine synthesis and use of dysmorphine, acetyl opium, and various fentanyl analogs. And with cocaine, while use is generally stable in Western Europe and showing slight decreases in the U.S., we are tracking emerging rapid-onset use in Africa.
The textbook explicitly mentions new trafficking routes causing a massive spillover effect in Africa, which actually brings me to a critical analytical point. You look at these deeply entrenched geographic clusters, and it is very easy for a layperson to assume that certain cultures are simply, biologically or socially predisposed to certain drugs. But the text makes a crucial second point here about the reality of supply.
It does. It introduces the essential epidemiological principle that geography is not necessarily destiny, but markets undeniably are.
Markets are destiny.
Yes. The persistence of illicit drug use in highly specific regions is rarely just about an inherent cultural preference for a specific molecule. It is predominantly driven by deeply established production capabilities, highly complex, resilient distribution networks, and the deep integration of these illicit economies into the local social and political fabric.
It's an economic engine.
It is. Once clandestine production is established in a region, it brings in immense, unparalleled profits compared to the negligible baseline production costs. It integrates into local culture, it provides massive employment in impoverished regions, and it often inevitably includes the systemic corruption of local governance and law enforcement. It becomes structurally incredibly difficult to dislodge.
And this is precisely where the double-edged sword of modern globalization comes into play, isn't it? The exact same systemic factors that optimize licit, legal trade, vastly improve transportation infrastructure, instant encrypted communication, the seamless fluidity of capital across digital borders, those exact same factors perfectly and ruthlessly optimize the diffusion of illicit drugs to entirely new markets.
Globalization has transformed the illicit drug trade with the exact same ruthless efficiency it brought to massive multinational corporations.
Yeah.
I mean, the supply chains are just as sophisticated, if not more so, because they must actively evade state detection.
Okay, let me push back on this framework for a second, just to test the logic. If we know exactly where these established international distribution routes are, and a coalition of law enforcement agencies goes in and forcefully, completely shuts down a major transit corridor, say, intercepting all maritime traffic in a specific Caribbean corridor, doesn't that mathematically solve the problem? You physically break the supply chain, the exposure drops, the public health crisis resolves.
This raises one of the most important questions in drug policy regarding the actual effectiveness of supply-side interventions. The historical and epidemiological data universally suggest a phenomenon that economists and criminologists refer to as the balloon effect.
The balloon effect.
Right. If you squeeze a long balloon tightly in one spot, the volume of air doesn't simply disappear into nothingness. It's forcefully displaced, and it bulges out somewhere else along the latex.
The pressure has to go somewhere.
Precisely. When law enforcement cracks down heavily on one established international distribution route, it rarely stops the overall global flow of the drug because the market demand and the profit margins are simply too high. Instead, it forces the trafficking organizations to rapidly reroute their supply lines. And here is the dire public health consequence of that displacement. Entirely new, localized drug markets and subsequent unprepared public health crises inevitably develop along those newly forged transit paths.
Like the emerging ATS and cocaine routes traversing West Africa that the UNODC data noted. The drug moves through the geographic area on its way to Europe. A certain percentage of it inevitably spills over into the local population because, well, transit fees are often paid in product rather than cash.
Yes, exactly.
When suddenly you have a brand new epidemic of severe substance use in a region that previously had absolutely zero exposure and no public health infrastructure to handle it.
That is the exact mechanism of geographic diffusion. Public health officials must operate under the grim assumption that illicit drug use will stubbornly continue where it is already established and will likely diffuse to entirely new areas over time. The market forces driving the supply are simply too robust for localized interdiction to permanently stop.
Which brings us to a massive, fundamental logistical problem in global public health. If these drug markets are constantly shifting like fluid dynamics, and the specific behavior we are trying to track is inherently illegal, stigmatized, and hidden, how do we actually measure any of this with any degree of scientific accuracy? We are talking about building a sophisticated epidemiological surveillance radar for an activity that actively, desperately wants to remain invisible. Measuring illegal behavior requires highly specialized epidemiological engineering.
It absolutely does. And the vital first step in that epidemiological engineering is acknowledging and quantifying the inherent systemic biases that plague this kind of data collection. First and foremost, you have the psychological hurdle of social desirability responding.
Right.
Human beings inherently want to present a favorable, socially acceptable image of themselves to authority figures, so they will naturally deny or heavily minimize their illicit drug use when asked directly.
Yeah, I mean, if a researcher in a lab coat with a clipboard asks you point blank if you've committed a federal felony recently, basic human preservation instincts dictate that you downplay it.
Second, you have the sheer logistical difficulty of physically locating the subjects who are at the highest risk. Many individuals who use illicit drugs at very high chaotic frequencies might be unstably housed, transient, or completely homeless. They don't have stable landlines. They aren't going to receive or respond to a mailed survey. They don't show up in standard census tracts.
Right.
And third, you have the biological reality that heavy chronic substance use, particularly when combined with high volumes of alcohol, can severely impair episodic memory, making retrospective self-reporting inherently unreliable.
So standard polling methodology is basically useless here. How does modern epidemiology actually engineer a solution for this?
Researchers have developed specific, highly effective technological and methodological workarounds. To directly combat social desirability bias, epidemiologists frequently utilize a CASI audio computer-assisted self-interviewing. The subject sits at a terminal, wears headphones, listens to the questions generated by a computer program, and privately enters their own answers on a keyboard or touchscreen.
It entirely removes the human interviewer and therefore the perceived human judgment from the equation.
Exactly. It doesn't require the subject to be highly literate, which removes another barrier, and the questions are presented with identical algorithmic neutrality to every single participant, standardizing the stimulus.
So you remove the fear of judgment and you get significantly cleaner data. But that still doesn't solve the most difficult problem. How do you find the hidden populations in the first place? You obviously can't just put an advertisement in the local paper asking for people who inject heroin to please come to the clinic for a survey.
This is where a brilliantly counterintuitive and mathematically rigorous method called respondent-driven sampling, or RDS, comes into play. Traditional random sampling methodology completely fails for marginalized hidden populations because there is no existing sampling frame. There is no master list of names to draw from. So RDS leverages the only functional mechanism that actually exists, the internal pre-existing trust networks within those hidden communities.
I remember reading the mechanics of this. You essentially provide a financial incentive for the initial subjects to recruit their peers, right? But hold on, let me challenge the statistical validity of that. If you pay people to recruit their friends, doesn't that completely ruin the randomness of the sample? What if you accidentally select one highly active, highly connected individual and they just recruit 50 of their closest friends who all share the exact same specific behaviors, the same specific drug dealer, the same specific risk profile? Doesn't that heavily bias the data and create a massive echo chamber?
That phenomenon is called homophily, the tendency of individuals to associate with similar people. And it is the exact statistical vulnerability that RDS is explicitly engineered to neutralize. You do not just hand out flyers and let them recruit endlessly. Strict mathematical restrictions are placed on the number of subjects any one individual is allowed to recruit, usually capped at just 2 or 3. They are given specific, physically numbered coupons to hand out to their peers.
Oh, I see. You essentially cap the recruitment tree to force it to branch out further away from the original source.
Precisely. This structural limitation prevents a single super recruiter from dominating the sample. And because the researchers meticulously track the unique coupon numbers, they know exactly who recruited whom. Statisticians can literally map the social network mathematically as a Markov chain. But the true genius of RDS is the weighting.
The weighting.
Yes. During the interview, researchers collect data on the size of the subject's personal network. Basically, how many other people who inject drugs do they know personally?
Why does the network size matter?
Because a highly connected person has a mathematically higher probability of being recruited into the study simply by virtue of knowing more people. To correct for this, statisticians mathematically downweight the data from highly connected individuals and upweight the data from isolated individuals. Through this complex mathematical weighting, by the 4th or 5th wave of recruitment, the sample reaches an equilibrium that is statistically independent of the initial non-random participants.
Wow.
Yeah, this allows us to make mathematically valid population-level inferences about the entire hidden group, not just the people who walk through the clinic door.
That is incredibly elegant. You're using the pathogen's own transmission vector, the social network, to mathematically map the invisible population. And what about the third bias, the biological memory issue?
For memory impairment, researchers employ the timeline follow-back method. Instead of just asking a broad, cognitively difficult question like, how many days did you use heroin in the last 90 days? The researcher works with the subject to identify major, highly memorable, idiosyncratic life events, holidays, birthdays, arrests, hospitalizations, the birth of a child, and uses those as rigid temporal anchor points.
Okay, that makes sense.
Right. They visually build a calendar with the subject and use those anchors to systematically reconstruct the specific daily behavior over long retrospective periods. It dramatically increases recall accuracy.
So those are the specialized microscopic tools used to dig deep into hidden populations. But what are the broad surveillance pillars? Like, how does a nation keep an eye on the exposure of the population as a whole?
Global public health relies on a synthesized mix of surveillance strategies, each serving a distinct, complementary purpose. First, you have broad household surveys of the general population, like the National Survey on Drug Use and Health, the NSDUH, in the United States. They rigorously interview over 67,000 people annually. This functions as your broad population-level early warning radar.
But the inherent limitation is that it's only catching people who are stable enough to reside in households. It misses the transient populations completely.
Exactly. Then you have school surveys, such as the Monitoring the Future study, Epidemiologically, adolescence is the critical vulnerable window for the initial onset of illicit drug use, so school surveys are vital for generating leading indicators and predictions about future adult trends. Third, you have administrative data, like the Treatment Episode Dataset, or TEDS. This specifically tracks formal admissions to licensed substance use treatment programs.
But administrative data is really just measuring the tip of the iceberg, isn't it? It's only capturing the specific subpopulation that has actively interacted with the system, the ones who voluntarily sought treatment or were mandated by the courts. It completely misses the vast, submerged majority of active users who never engage with the healthcare apparatus.
That is the crucial distinction. Administrative data measures the systemic burden on the healthcare infrastructure. It does not measure the true epidemiological prevalence in the community. And finally, to bridge these gaps, you have special studies. While the NSDUH is the broad, sweeping radar, special studies are the highly targeted investigations. They purposefully recruit high-frequency, severe users, like persons who inject drugs, often directly from clinical settings or through aggressive community outreach, to deeply examine specific, localized risks like the mechanical transmission of HIV.
Okay, so we've successfully mapped the macro population. We understand how global market forces move the drugs, and we understand the highly specialized epidemiological tools we use to quantify the exposure. Now, let's zoom in from the population level to the clinical level. Let's look at the specific clinical definition of the outcome itself. How does the medical system actually categorize a problem user? Because the history of psychiatric diagnosis in this specific area is, well, it's a history of getting it fundamentally wrong for a long time.
To understand the diagnostic framework we use today, you have to understand the historical evolution of the criteria, specifically the monumental transition from the DSM-IV to the DSM-5. Because for decades, the medical system operated under a model that was biologically and statistically flawed.
Let's unpack that history. What was the specific structural flaw in the DSM-IV?
The DSM-IV, published in 1994, established a strict hierarchical distinction between two distinct categories, substance abuse and substance dependence.
And how did it delineate the two?
Abuse was defined entirely by the negative social and functional consequences of use. Things like engaging in physically hazardous use, neglecting major role obligations at work or home, persistent social or interpersonal problems, and recurrent legal problems. You only needed to meet one of these criteria to receive an official abuse diagnosis.
Just one, okay.
Yeah. Dependence, on the other hand, was primarily characterized by physiological and behavioral components. Biological tolerance, physical withdrawal, using more of the substance than intended, and unsuccessful repeated efforts to quit. You needed to meet 3 or more of these criteria for a dependence diagnosis.
From a purely intuitive standpoint, that seems somewhat logical. You have the external social fallout in one box, and you have the internal physical biological trap in the other box.
It seemed highly logical to clinicians at the time, but it rested on a massively flawed, untested assumption. The psychiatric field universally assumed that abuse was the milder, early prodromal stage of the disease, and that dependence was the more severe, advanced biological stage. The DSM-IV actually codified this unproven hierarchy into its rules. You were explicitly forbidden from diagnosing someone with abuse if they simultaneously met the criteria for dependence.
Interesting. So how do we prove a diagnostic manual is wrong? We can't simply run a blood test for a psychiatric category. What did the data actually show that caused this model to collapse?
The definitive evidence against the DSM-IV model came from massive, rigorous statistical analyses using item response theory, or IRT. The DSM-5 Substance Disorders Workgroup analyzed 39 different independent IRT studies encompassing over 200,000 subjects globally.
And for those listening who might not be deep into psychometrics, item response theory is a sophisticated statistical method that doesn't just look at whether someone simply has a symptom, but it measures how strongly that specific symptom correlates to the underlying severity of the invisible latent trait we are trying to measure. In this case, the true underlying severity of the substance disorder.
Precisely. It mathematically evaluates how well each individual symptom performs as a marker of the overall disease. And these massive IRT studies revealed 2 undeniable, mathematically proven facts that completely shattered the DSM-IV model. First, they proved conclusively that abuse and dependence criteria were unidimensional. They were not 2 separate, distinct clinical conditions. They were measuring the exact same underlying latent disorder. Second, and this was the paradigm-shifting realization, the abuse and dependence criteria were intermixed all across the severity spectrum.
Meaning the social consequences weren't necessarily the mild early warnings, and the physical symptoms weren't necessarily the severe end-stage markers.
Exactly. Abuse was not merely a stepping stone to dependence. A patient might have severe, escalating physiological tolerance, a dependence criterion, but possess enough wealth and social support to experience absolutely no social or legal fallout. Conversely, a patient might experience massive social disruption from highly hazardous binge pattern use and abuse criterion, but experience zero physical withdrawal between binges.
Which brings us to a phenomenon that the textbook highlights, which I find incredibly tragic from a systemic public health perspective, the diagnostic orphans.
Yes. Because of the strict categorical criteria requiring 3 symptoms for dependence or 1 for abuse, you had patients who presented in the clinic with, for example, massive physiological tolerance and a persistent, desperate desire to quit. That constitutes 2 dependence criteria.
Right.
But because they didn't quite meet a 3rd dependence criterion, and because they managed to hold down their job and avoid arrest so they had 0 abuse criteria, they received absolutely no official diagnosis.
They were completely invisible to the medical system.
They were diagnostic orphans. And longitudinal follow-up studies showed these specific orphans often had far more serious, complex clinical profiles and higher morbidity than patients who successfully received a diagnosis simply by meeting a single, isolated abuse criterion, like being cited for driving under the influence one time. It represented a massive systemic failure in catching highly at-risk patients and effectively directing them to life-saving treatment.
So what does this complex statistical evolution mean for the clinician operating today? The DSM-5 is published in 2013 to rectify this failure. What exactly did they engineer? Did they just move the goalposts?
It wasn't about moving goalposts. It was about completely tearing down the rigid categorical boxes and building a continuous volume dial. The DSM-5 completely eliminated the hierarchical distinction. They combined the abuse and dependence criteria into a single unidimensional diagnosis called substance use disorder, or SUD.
And they tweaked the specific diagnostic criteria themselves based on the IRT data, right? They completely dropped the legal problems criterion. Why? Because to a layperson, getting arrested for drug possession seems like an incredibly clear indicator that you have a severe drug problem.
It seems highly intuitive, but statistically it was completely useless. The psychometric work group found it had very low overall prevalence across clinical populations. It fit extremely poorly with the other criteria in the IRT mathematical models. And crucially, it had a terrible discrimination parameter.
Meaning what, exactly?
Meaning it measured socioeconomic status and systemic policing bias far more than it measured the biological severity of the addiction. A wealthy patient with a severe, life-threatening opioid habit could afford elite lawyers to avoid a legal conviction entirely, while an impoverished patient with a relatively mild cannabis habit might get arrested and convicted immediately due to aggressive local policing. When they ran secondary analyses on vast sets of existing clinical data, they found that dropping the legal problems criterion caused exactly 0 true patients to lose their diagnosis. It added absolutely no clinical value to the assessment of the biological disorder.
But they did add something entirely new to the list: craving.
Yes. Decades of biological, neuroimaging, and behavioral studies heavily supported the inclusion of craving as a central, profound driving force in compulsive drug use. So they dropped legal problems, added craving, and established a finalized 11 criterion list for substance use disorder.
And getting back to that volume dial analogy.
Right. Instead of binary categorical thinking, you either have abuse or you have dependence, the DSM-5 shifted entirely to dimensional thinking. It recognizes the disorder exists on a spectrum. If you meet 2 to 3 of the 11 criteria, it is diagnosed as mild SUD. If you meet 4 to 5, it is moderate. If you meet 6 or more, it is severe. This lower threshold of requiring just 2 criteria successfully, and finally, capture the diagnostic orphans without artificially or dangerously inflating overall population prevalence rates.
Here is where the textbook notes something that is really fascinating to me regarding the sociology of medicine. The name itself: substance use disorder. The text notes there was massive heated tension over this terminology within the psychiatric community. Why not just call it addiction or dependence?
Well, the finalized term substance use disorder was an explicit, highly calculated compromise. The psychiatric field was deeply philosophically fractured. One faction wanted to use the term addiction to describe the severe compulsive behavior and wanted to reserve the word dependence strictly for the normal, expected physiological neuroadaptation that happens even with correctly prescribed medically necessary medications, like a patient taking beta blockers.
Right. Your body depends on them, but you aren't addicted to them.
Exactly. But both addiction and dependence had become highly stigmatized, culturally loaded words, and there was grave concern that general medical practitioners were already deeply confusing the terms, leading to patients being inappropriately tapered off necessary medications because the doctor feared they were dependent. Substance use disorder successfully bypassed the academic infighting and the public stigma entirely.
It is a neutral, precise clinical descriptor. All right, so we have deeply defined the disorder. We know exactly how to diagnose the outcome of the exposure. Let's move further downstream to the consequences. Because the severe physiological reality of substance use disorders, particularly concerning opioids and stimulants, frequently leads to injecting behaviors. And the precise moment a needle enters the equation, we fundamentally transform a chemical dependency issue into an explosive, infectious disease vector.
This is the exact inflection point where the mortality risk of the disorder multiplies exponentially. The mere use of psychoactive drugs always carried a certain baseline risk of death, usually from acute overdose or traumatic accidents. But the emergence of blood-borne pathogens, specifically HIV and hepatitis C, changed the epidemiological landscape completely and permanently.
Let's start with HIV and AIDS. The text paints a remarkably grim historical picture of how this unfolded in the population.
HIV was first formally noted among persons who inject drugs, or PWID, in 1981. And what immediately terrified public health officials globally was the sheer relentless velocity of the viral transmission. HIV can spread at terrifying exponential speeds within interconnected injecting networks. As you mentioned in your introduction, the textbook highlights the catastrophic epidemic in Bangkok, Thailand in 1989. The HIV prevalence among injecting drug users there increased by approximately 4% per month.
4% per month. We have to dive into the mechanisms here. How does a virus physically, mechanically move through a human population with that kind of terrifying velocity? It can't just be individuals occasionally sharing a needle with a friend.
No, it requires highly specific, highly efficient mechanical vector mechanisms, physical environments that actively generate rapid injecting partner change and mass fluid exchange. You have environments known as shooting galleries, where highly marginalized users rent a single needle and syringe, inject their dose, and immediately return it to the gallery operator, who then immediately rents that exact same contaminated equipment to the next person in line. You also have dealers' works, where the individual selling the drug provides a communal syringe for their customers to use on-site.
And the textbook also mentions hit doctors.
Yes, individuals who, for a small financial fee or a portion of the drug, will physically inject users who have difficulty finding a viable vein themselves due to severe vascular damage. The hit doctor might use their own single syringe on dozens of different clients in a single day. When you combine these highly efficient mechanical mixing environments with the biological fact that HIV is exceptionally infectious during the acute early stage of infection, when viral loads are astronomically high, you get explosive, unstoppable transmission.
Okay, so that perfectly explains the velocity of HIV. It relies on direct blood-to-blood contact through a shared needle in a high-turnover environment. But the text draws a massive fundamental distinction between the transmissibility of HIV and hepatitis C, or HCV. Why is HCV so much more prevalent globally?
The profound difference lies in environmental resilience and the threshold of transmissibility. HIV is a relatively fragile virus outside the human body. It generally degrades rapidly and requires the direct sharing of the needle or the syringe itself, the actual reservoir of fresh blood, to transmit effectively. HCV is a vastly tougher pathogen. It is highly environmentally resilient and highly transmissible. It can survive for days or even weeks outside the body. Crucially, it can spread effectively, not just through the needle, but through the sharing of the peripheral drug preparation equipment.
Explain that microenvironmental fluid exchange.
When individuals prepare a drug for injection, they place the powder in a small receptacle called a cooker, add water, and heat it. They then draw the liquid up through a small cotton filter to remove impurities. Even if two users have their own completely sterile brand new syringes, if they both draw their respective doses of the drug from the exact same cooker or through the exact same cotton filter, HCV can and will transmit.
Because the virus survives the cooking process and contaminates the shared reservoir.
Exactly. And because the mechanical barrier to transmission is so much lower, the population prevalence is phenomenally higher. While HIV prevalence might peak at 10 or 20% in a high-risk injecting group, HCV affects an estimated 10 million PWID globally. Country-specific prevalence ranges from a baseline of 10% to over 80%, and in at least 12 countries, it exceeds a staggering 80% of the entire injecting population.
So if we connect this biological reality back to the bigger picture, to our system impact, How have our structural interventions fared against these two very different viruses?
We have seen massive historic success against HIV using harm reduction programs, specifically needle and syringe programs, or NSPs. In geographic areas with high sustained coverage of NSPs, HIV incidence has been successfully driven down to less than one new infection per 100 person years. By flooding the environment with sterile syringes, we can essentially avert or completely halt an HIV epidemic.
But because HCV is so much more resilient and relies on the peripheral equipment.
Exactly. Nowhere in the world has combined prevention lowered HIV incidence to that level. The NSPs provide clean needles, but preventing the sharing of cookers, water, and filters in chaotic, impoverished environments is profoundly difficult.
But here's where the science gets truly remarkable. We actually have the biological cure for one of these, right? Not just management, but a literal functional cure.
We do. For HIV, we have antiretroviral therapy, or ART, which is undeniably life-saving and suppresses the virus to undetectable levels, but it is not a cure. It requires lifelong adherence and management. But for HCV, the recent development of direct-acting antivirals, or DAAs, like Telepraver, completely revolutionized the hepatology field.
The textbook refers to this as SVR.
Yes, sustained virological response. That represents the functional permanent eradication of the virus from the body. It is a true cure. And the new DAAs achieve this SVR in up to 75% of patients with genotype 1 infection, and they achieve it without the brutal, severe psychiatric depression side effects that characterize the older, poorly tolerated interferon-based treatments.
So we have a highly infectious pathogen ravaging a highly marginalized population, and we have engineered a pharmaceutical cure that works beautifully and doesn't cause severe psychiatric side effects. So problem solved, right? We just deploy the cure.
If only public health were that simple. This is precisely where the medical miracle crashes violently into the brick wall of structural inequity and system design. The text estimates that actual access to HCV treatment for active PWID is less than 5% in wealthy, developed nations like the United States and Australia.
Less than 5% access to a literal cure. Why? What is the systemic bottleneck?
It is a devastating combination of structural factors. First, the initial exorbitant cost of the DAA medications was astronomical, placing immense strain on public health budgets. Second, you face stringent, often scientifically unfounded requirements from insurance providers and state Medicaid boards who frequently demand months of documented, strict abstinence from illicit drugs before they will approve the medication. And third, the tertiary healthcare system itself is deeply complex, fragmented, and often inherently hostile to active drug users, making the navigation of multiple specialist appointments nearly impossible for unstably housed individuals.
And when we look globally, especially in low and middle income countries, the structural barriers become even more insurmountable. The textbook offers some intense analysis on the role of policy and national governance here.
It does, and it pulls no punches. The text highlights how national policy literally dictates biological pathology. You simply cannot separate the mechanical spread of the virus from the legal architecture governing the population.
The Russian narcology model is used as the primary stark example of this dynamic.
It serves as a profound public health cautionary tale. In Russia, opiate substitution therapies like methadone and buprenorphine, which we know stabilize patients and reduce injecting, are legally banned. The political leadership has historically culturally framed these evidence-based medical treatments as Western decadence and refused to implement them. Furthermore, the state maintains official punitive registries of known drug users, and being placed on that registry can strip individuals of vital civil rights, including the right to drive or hold certain employment.
So what is the systemic epidemiological outcome of that specific policy design?
The inevitable outcome is that drug users are driven deep underground. If carrying a clean, sterile syringe on your person exposes you to severe police harassment, arrest, and placement on a civil registry, you simply don't carry clean syringes. You use whatever contaminated equipment is currently available in the hidden, rapid turnover injecting sites. The policy actively creates and enforces the exact mechanical environment necessary for rapid viral transmission. The text makes the clinical reality very clear. When a state criminalizes the basic tools of survival, punitive policy becomes the pathogen's absolute best friend.
Which is a terrifying realization of how law shapes biology. So we've extensively covered the chronic infectious consequences of the needle. Let's shift our focus to the acute consequences. If infectious disease is the chronic toll of the delivery method, overdose is the acute catastrophic failure caused by the molecule itself.
And the epidemiological data on fatal overdose reveals some startling, massive geographic disparities that demand explanation. If we look at the European Union data from 2011, the broad average was 21 fatal overdoses per million in the population. But the internal variance within that average is massive. In Romania, it was remarkably low, less than 5 deaths per million. In Estonia, it was an astronomical 150 per million.
That is a 30-fold difference on the exact same continent, largely driven by the specific introduction of illicit fentanyl into the Estonian market. And what about the United States? The text highlights the U.S. data from 2010 as a massive, alarming anomaly.
The U.S. overdose data from 2010 signals the leading edge of a profound, systemic epidemiological shift. Out of 38,329 total overdose deaths recorded that year, over 16,600 were driven not by clandestine street heroin, but by legally manufactured pharmaceutical opioid analgesics. And what makes this specific crisis uniquely lethal is the dangerous concurrent prescribing of other powerful psychotropic drugs by the medical system itself.
Right. Patients aren't just taking one isolated pill, they are dealing with polypharmacy.
Exactly. The text rigorously notes that opioids were frequently implicated in overdose deaths that also involved benzodiazepines in over 77% of cases and antidepressants in over 57% of cases. You have the healthcare system inadvertently combining massive synergistic pharmaceutical respiratory depressants.
Let's dig deep into that physiology. What is the actual mechanical sequence of death in a narcotic overdose? Why does the human body simply shut down?
The primary mechanism of death in an opioid overdose is severe respiratory depression. The opioid molecules enter the brain and bind forcefully to specific mu-opioid receptors located in the brainstem, particularly in an area called the pre-Butzinger complex, which functions as the brain's respiratory pacemaker. These receptors control the automatic subconscious drive to breathe. Normally, your brain triggers a breath when it senses rising levels of carbon dioxide in the blood, but the opioids intensely desensitize the brainstem to that carbon dioxide buildup. They essentially tell the brain to stop sending the electrical signal to the diaphragm and lungs. The person loses consciousness, their respiratory rate slows dramatically, becomes dangerously shallow, and eventually stops entirely. Severe hypoxia sets in, brain damage begins within minutes, and the heart ultimately stops.
It is a quiet chemical suffocation. And there is a highly specific, deeply dangerous physiological trap mentioned in the text that clinicians need to be hyper-aware of. It's what I call the post-treatment danger zone.
This is a critical point of clinical vulnerability that is often tragically misunderstood by both patients and their families. When a person with severe opioid dependence is actively using on a daily basis, their brain rapidly adapts to the chemical flood. They build a profound biological tolerance, requiring massive escalating doses of the drug just to function normally and avoid withdrawal doses that would instantly paralyze the respiratory system of a naive, non-tolerant user.
Because the brain downregulates the sensitivity of the receptors to survive the constant chemical assault.
Exactly. But when that person enters a treatment program, goes through detoxification, or spends a period of time incarcerated, they undergo a forced period of abstinence. During that time, their brain's neuroadaptation resets. The receptors upregulate, they completely lose their protective biological tolerance.
So if they experience a relapse...
If they relapse a week, a month, or even a year later, the psychological craving often drives them to reach for their historical normal maintenance dose, the dose their brain remembers. But their physical body can no longer handle that dose. What used to be their baseline maintenance requirement is now a massive, instantly lethal overdose. The receptor saturation is absolute, and the respiratory depression is immediate and catastrophic.
Okay, let me use an analogy here to ground this. If the loss of biological tolerance is the icy, treacherous road, and the inevitable relapse is the high-speed crash, or is the seatbelt, how do we stop them from dying right there on the pavement before the ambulance even arrives?
The seatbelt is naloxone.
Also known by the brand name Narcan.
Yes. Naloxone is a remarkably potent, highly specific narcotic antagonist. It has a significantly stronger binding affinity for the mu-opioid receptors in the brainstem than the drug itself, be it heroin, oxycodone, or fentanyl.
Right.
But it has zero intrinsic efficacy. It doesn't activate the receptor, it just blocks it. If administered during an active overdose, it physically knocks the lethal opioids off the receptors and immediately reverses the respiratory depression. A person could go from cyanotic, blue, and apneic to sitting up, breathing, and talking within minutes.
And the crucial public health intervention here isn't just stocking naloxone in hospital emergency rooms, right?
No, because by the time a bystander recognizes the overdose, calls emergency services, and the ambulance physically navigates to the location, the anoxic brain injury is often already fatal. The paradigm shift which the textbook highlights, effectively using the North Carolina distribution program as a model, is placing this vital downstream rescue tool directly into the hands of the lay people who are actually present during the critical minutes of an overdose. The drug users themselves, their peers, and their family members. You decentralize the life-saving intervention.
Which is a perfect logical segue into our intervention architecture. We know the macro market forces. We know how to accurately diagnose the disorder using the dimensional DSM-5 criteria. We understand the pathogen vectors, and we fully grasp the lethal mechanical physiology of overdose. So what is our comprehensive clinical blueprint? How do we actually intervene and rebuild the bridge? And the foundational philosophical concept here, as the text heavily emphasizes, is that we must treat substance use disorder not as an acute infection that you definitively cure with a 10-day round of antibiotics, but as a complex chronic relapsing condition.
That is the essential, non-negotiable mindset shift for any clinician. Relapse is not a moral failure of the patient, nor is it a definitive failure of the treatment protocol. It is an expected, recognized symptom of the chronic neurobiological condition itself. And the World Health Organization outlines a comprehensive package for treatment, but at the absolute core are several distinct, scientifically validated modalities.
Let's walk through them methodically. First up is the pharmacological foundation, OST, opioid substitution treatment.
This involves the administration of carefully controlled pharmacological medications like methadone and buprenorphine, which the WHO rightly considers essential medicines for any functioning healthcare system.
How do they work mechanistically to stabilize the patient? We just said opioids cause the problem, so why are we giving them more opioids?
Because the pharmacokinetics are fundamentally different. Methadone is a full opioid agonist, and buprenorphine is a partial agonist. But critically, they both have exceptionally long half-lives and a very slow onset of action compared to injected heroin or fentanyl. They bind tightly to the same receptors, effectively preventing the agonizing symptoms of physical withdrawal and neutralizing the intense, all-consuming psychological craving. But because they are long-acting and maintain a stable serum level, they do not produce the disruptive, intoxicating euphoric spike, nor do they cause the subsequent crashing withdrawal that drives the chaotic cycle of illicit acquisition. By stabilizing the brain chemistry, OST dramatically reduces the frequency of illicit drug use, slashes the rate of sharing injection equipment, and significantly improves the overall quality of life, employment retention, and social functioning of the patient.
Okay, so OST stabilizes the biological hardware, but what about the psychological software? The text brings up CBT, cognitive behavioral therapy.
CBT recognizes that prolonged addiction deeply and powerfully rewires learned associations in the brain. It seeks to actively recruit the prefrontal cortex, the logical, planning, executive control part of the brain, to override the hyperactive, primitive limbic reward circuitry. CBT specifically targets the cognitive distortions and situational triggers that predictably lead to drug use.
How does it actually achieve that in clinical practice?
It focuses on building robust coping mechanisms and explicitly training what we call drug refusal skills. The goal, as the text notes, is to systematically and repeatedly disassociate internal emotional states like severe anxiety or depression or external environmental cues, like seeing a specific street corner or feeling a specific type of stress from the deeply ingrained automatic conditioned response of drug use. It is cognitive reprogramming.
So CBT relies heavily on top-down logic and planning. The next modality, CM or contingency management, seems to rely on something much more primal and immediate.
It does. Contingency management is pure, highly structured operant conditioning. It actively leverages the exact same primitive dopaminergic reward circuitry that the drugs hijacked in the first place, but it therapeutically redirects it toward health-seeking behaviors.
Basically, we systematically pay them to stay clean.
In a highly structured, scientifically monitored therapeutic way, yes, you utilize alternative, highly desirable non-drug reinforcers, which could be escalating vouchers, small prizes, or direct cash to instantly reward objective, verifiable evidence of positive behavior, such as providing biologically clean urine tests or maintaining perfect attendance at scheduled clinic sessions.
But hold on, if CM relies entirely on continuous rewards, human nature dictates that the patient will eventually test the boundaries. If they fail a drug test and you just take the reward away, doesn't that trigger the exact emotional crash and feelings of failure that lead to a massive binge? How does the clinic handle the behavioral reset without losing the patient?
That is a phenomenal clinical question. The system is designed to be completely predictable and non-punitive. When a patient provides a positive sample, the clinician doesn't shame them or eject them from the program. The escalating incentive simply, mechanically resets to the baseline level. It is a highly immediate, strictly predictable system of rewards and consequences that the patient fully understands. And the empirical data shows it works phenomenally well for driving short-term, dramatic behavioral changes. It essentially keeps people retained in treatment much longer during the highly vulnerable early phases, which gives the slower therapies like CBT the necessary time to actually work. But it is important to note the text points out there is evidence of diminishing returns over very long periods. CM is a powerful jumpstart, but it is not a lifelong engine.
Fascinating. Okay, the fourth major psychosocial modality, MI, motivational interviewing.
MI specifically targets the internal, paralyzing psychological barrier of ambivalence. People suffering from severe SEDs often feel deeply agonizingly conflicted. A logical part of them desperately wants to quit because they see the destruction, but a deeply conditioned part of them is absolutely terrified of the withdrawal or genuinely feels they need the drug simply to survive the day. Traditional, old-school confrontational therapy, where the clinician aggressively tells the patient what to do and lists all the reasons they are failing, often just provokes intense psychological resistance and drives the patient away.
So what does MI do differently to bypass that resistance?
In MI, the clinician acts more like a collaborative guide than an authoritative dictator. Through highly specialized empathetic dialogue techniques, they help the client safely explore and resolve their own internal ambivalence. The ultimate goal is to gently shift the conversation so that the client themselves starts organically generating what we call commitment language, where the patient, out loud, begins expressing the desire, the ability, the specific reasons, and the need to change. When the motivation for change is articulated from within the patient, rather than imposed from the outside, it is far more durable and resilient against relapse.
Okay, those are the highly effective psychosocial tools. Now let's talk about the physical, immediate hurdle of stopping use. Detoxification. Let me challenge the premise here. Why even bother with a standalone detox facility if, as we explicitly established earlier with the post-treatment danger zone, relapse is almost statistically guaranteed and incredibly lethal without long-term medication?
That is perhaps the most crucial clinical insight of this entire discussion. You shouldn't. Standalone detoxification, which is essentially just locking someone in a secure medical room and managing their symptoms until the drugs are physically cleared from their system, is fundamentally not a treatment for the underlying disorder. It is merely the doorway. And without subsequent immediate linkage to long-term pharmacological support like OST or intense psychosocial support, standalone detox has immense, almost universally guaranteed rates of treatment dropout and subsequent lethal relapse.
The textbook explicitly mentions the Russian system again here to illustrate this failure.
Right. The Russian narcology model is, once again, the grim cautionary tale of ignoring biological reality. They aggressively enforce inpatient detoxification, but because they legally ban access to proven pharmacological follow-up, like methadone or buprenorphine, the textbook describes the systemic outcome as a great leap backwards in public health. You put the vulnerable patient through the absolute physical agony of withdrawal, you completely strip away their protective biological tolerance, and then you discharge them right back into the exact same high-risk environment with zero biological armor and zero craving blockade. It is a recipe for fatal overdose.
So medically supervised detox must be inextricably paired with long-term structural support. And one vital form of that long-term support mentioned in the text is self-help and 12-step programs, like Narcotics Anonymous or Cocaine Anonymous.
Yes. These peer-led programs provide something that formal, scheduled medical clinics often simply cannot: an immediate, highly accessible, massive change in the individual's daily social network. Because severe drug use is often deeply intertwined with specific peer groups and social environments, completely avoiding previous social networks is utterly vital to avoiding cue-induced relapse. 12-step programs embed the isolated individual in an entirely new, highly supportive community built strictly around abstinence, shared experience, and mutual support, and they provide it globally at zero financial cost to the healthcare system.
Okay, we are nearing the very end of our journey upstream. We have reached the final layer of our architecture. Because ultimately, all of these advanced clinical tools, the OST protocols, the AXA surveillance surveys, the massive naloxone distribution networks, they are all governed and bound by our overarching societal ethical frameworks. This brings us to the core philosophy that governs modern, evidence-based public health responses to drug use globally: harm reduction.
Harm reduction is both a highly practical set of epidemiological strategies and a profound moral and philosophical stance. Its foundational principle is that it accepts, objectively, for better or worse, that illicit drug use currently exists and will continue to exist in our world. Rather than demanding immediate perfection, it chooses to work pragmatically to minimize the devastating harmful effects of that continued use, rather than simply ignoring the users, criminalizing their health status, or condemning them for not immediately achieving total abstinence.
It fundamentally views drug use and recovery on a long, continuous spectrum, right?
Exactly. It recognizes a continuum of behavior, ranging from severe, highly chaotic, life-threatening abuse all the way to total sustained abstinence, and it objectively acknowledges that some specific methods of using drugs are demonstrably biologically safer than others. Using a sterile, clean needle is objectively safer than using a contaminated, dirty one. Using opioids with a peer holding naloxone present in the room is objectively safer than using alone behind a locked door.
And crucially, it completely changes the definition of systemic success.
This is the massive paradigm shift for public health. The primary overriding metric of success in a harm reduction framework is the measurable quality of individual and community life, not the strict biochemical cessation of all illicit drug use. It demands the non-judgmental, low-barrier provision of vital medical services, and it rigidly insists on actively incorporating the lived experiences and voices of the drug users themselves in the actual design and implementation of those life-saving programs.
Let me play devil's advocate and push back with a classic, deeply entrenched political critique. Some critics, including very powerful political figures and policymakers, hear the term harm reduction, they see a needle exchange, and they genuinely believe it just means giving up on patients. They argue it is actively condoning and facilitating illegal, destructive behavior and abandoning the ultimate hope of full recovery and societal reintegration.
The overwhelming academic, epidemiological, and scientific consensus, which the textbook rigorously details and supports with decades of data, is that harm reduction is absolutely not giving up. It is a rational, evidence-based recalibration of clinical reality. It does not for a second attempt to minimize the profound tragedy, the danger, or the systemic cost of severe drug use. But it synthesizes a fundamental biological and evolutionary truth. Because the human nervous system's innate reward pathways are so highly susceptible to the powerful dopaminergic spikes caused by these specific molecules, a totally flawlessly drug-free world is a biological and mathematical impossibility.
We simply cannot arrest our way out of fundamental human neurobiology.
Precisely. Therefore, denying the fundamental human rights of drug users, denying them access to basic sterile medical equipment to prevent HIV, denying them access to essential stabilizing medicines like methadone because of ideological objections, does not magically stop illicit drug use. The data shows it simply brutally exacerbates the mortality and morbidity rates. Health is a fundamental human right, regardless of a person's current legal status or their current capability to achieve total abstinence.
So the core of harm reduction is about aggressively saving lives where the user is at today. Now.
You aggressively keep them alive. You keep them free from entirely preventable infections like HIV and hepatitis C today so that they physically survive long enough to potentially seek, engage in, and succeed in comprehensive treatment tomorrow. The grim, undeniable reality of public health is this: dead patients cannot recover.
Dead patients cannot recover. That is the ultimate, undeniable bottom line that should guide our clinical reasoning. And that brings us to the end of our deep dive. We've successfully navigated the river system, tracing the currents from the macro forces of global markets down to the molecular actions at the biological receptor and back up to the complex ethical frameworks governing our policies. I want to leave you, the listener, with a systems-level, highly provocative thought to mull over and apply to your practice. We learned today that dropping the punitive legal problems criterion in the DSM-5 actually made our medical diagnosis of substance use disorder statistically more accurate and valid. We also learned from the global data that punitive, heavy-handed law enforcement rarely stops the massive flow of international drug markets. It merely violently reroutes them, inevitably creating entirely new public health crises in unprepared regions. So here's the question you must ask yourself as a clinician and a citizen. Are our rigid, highly punitive legal and justice systems fundamentally at odds with the complex, dimensional, biological reality of human neuroadaptation?
It is a profound, systemic question that every single medical and public health professional must eventually confront in their career.
All right, let's lock in the architecture we've built today. It is time for our clinical recall challenge. I'm going to present 6 rapid-fire scenarios or concepts based directly on the textbook. I will pose the question, give you a few seconds so you can actively test your own recall, and then the expert will deliver the precise answer and tell you exactly which section of the Oxford chapter you should revisit if you need to consolidate the concept. Ready? Let's begin. Question 1. What highly specific methodological and structural change was made in the transition from the DSM-IV to the DSM-5 regarding the classification of substance use disorders to address the issue of diagnostic orphans? Take 3 seconds to think.
The answer is the categorical abuse and dependence criteria were fully combined into a single unidimensional diagnosis called substance use disorder. Additionally, the clinically unhelpful legal problems criterion was completely dropped, and the neurobiologically central criterion of craving was added. You can review the details of this transition in the section titled Dependence Addiction Disorder.
Question 2. Looking at the global epidemiological data, which illicit psychoactive drug commands the highest universal prevalence, with an estimated staggering 120 to 224 million active users. Lock in your answer.
The answer is cannabis. It remains the most widely used illicit substance globally by a significant margin. Review the exact prevalence breakdowns under the section Current Global Patterns in Drug Use.
Question 3. From an infectious disease perspective, why is hepatitis C or HCV prevalence generally vastly higher than HIV prevalence among populations of persons who inject drugs, even in areas with established needle exchange programs? Take a moment.
The answer is HCV is highly environmentally resilient and highly transmissible. Unlike HIV, it can be effectively and rapidly spread not just through the direct sharing of needles, but through the microenvironmental sharing of peripheral drug preparation equipment, such as cookers, rinse water, and cotton filters. Review the specific mechanisms in the section on infectious diseases. Question 4. What is the exact underlying psychological and neurobiological principle utilized in contingency management, or CM, treatment for severe substance use disorders? Think about the mechanism. The answer is CM utilizes strict operant behavior conditioning, leveraging the brain's reward pathways by providing alternative, highly desirable non-drug reinforcers, such as financial vouchers, to instantly reward objective, verified evidence of treatment retention and biological abstinence. Review the efficacy of this modality in the section on treatment of substance use disorders.
Question 5. Consider this clinical scenario. A patient successfully completes a rigorous inpatient opioid detoxification program. They tragically experience a relapse 1 week after discharge. What precise physiological mechanism makes this specific post-treatment period uniquely and highly risk-prone for a rapid, fatal overdose? Give it some thought.
The answer is the complete loss of protective biological tolerance during the forced abstinence period. The brain's receptors upregulate, meaning that taking their previously normal historical maintenance dose instantly causes massive receptor saturation and fatal respiratory depression. Review this critical trap under the section Drug-Induced Overdose Deaths.
Question 6. True or false? Medically supervised standalone detoxification without any subsequent linkage to long-term pharmacological support like OST or intensive psychosocial treatment is an evidence-based, effective long-term intervention for severe opioid dependence. True or false?
The answer is false. Substance use disorders are complex, chronic, relapsing conditions. Detoxification alone merely manages acute withdrawal. Without vital maintenance medications like methadone or buprenorphine to block cravings, standalone detox is associated with exceedingly high, almost guaranteed rates of clinical dropout and lethal relapse. Review the data on this in the section on residential treatment and detoxification.
Well done. Remember the core lesson today. If we truly want to save lives, we must rigorously commit to fixing the bridge, not just pulling people out of the water after they have fallen. Here are the details of this episode.
Public health aspects of illicit psychoactive drug use. Byline: Global patterns, health harms, and population responses to illicit drug use. Byline episode description. Illicit psychoactive drug use is a significant contributor to global morbidity and mortality. Although its overall burden is smaller than that attributable to tobacco or alcohol, illicit drug use generates substantial health, social, and economic consequences, including overdose deaths, infectious disease transmission, mental health disorders, and social disruption. This episode explores global prevalence patterns of cannabis, opioids, cocaine, and amphetamine-type stimulants. This episode explores drug-related mortality and disability-adjusted life years, Davis funds. This episode explores geographic variation in production, trafficking, and consumption. This episode explores injection drug use and the transmission of HIV and hepatitis. This episode explores overdose epidemiology and the opioid crisis. This episode explores the neurobiology of dependence and relapse. This episode explores harm reduction strategies, needle exchange, opioid substitution therapy. This episode explores prevention, treatment, and policy responses. This episode explores the intersection of drug use, incarceration, and social inequity. This episode explores illicit drug use is shaped not only by individual vulnerability, but by structural forces, production economies, trafficking routes, criminal justice systems, and social marginalization. Public health responses increasingly recognize that punitive approaches alone are insufficient. This episode explores. The episode highlights the importance of evidence-based harm reduction, treatment accessibility, and integrated policy approaches that address both individual behavior and structural determinants. This episode explores. Illicit drug use contributes significantly to global morbidity and mortality. This episode explores. Cannabis is the most widely used illicit drug globally. This episode explores. Opioid use is strongly associated with overdose and infectious disease transmission. This episode explores. Harm reduction strategies reduce HIV, hepatitis, and overdose risk. This episode explores. Substance use disorders are chronic, relapsing conditions. This episode explores. Criminal justice responses have population health consequences. This episode explores. Public health frameworks prioritize prevention, treatment, and structural reform.